uh, topo-guided PRK and intacs in keratoconus. Again, laser is been a controversial topic for keratoconus, and many times we have looked at option of non-ablative versus ablative options. However, over the last few years, many things have changed, and probably people are accepting this much better than what they were a few years back. When you look at topo-guided treatments, what comes to mind is why do we need to do a topo-guided? Means why not the complete optical the system that we treated? I think personally that would be the best way to do it, because when you're doing a topo-guided treatment, you try to regularize the surface of your anterior cornea without really looking at the complete optics of the cornea. And wavefront is one which would probably look at a complete system. Then why topo-guided? The problem is not with the treatment. The problem is with the aberrations, which are difficult to pick up by the machines. And many times you end up with having a very poor quality of images. So we are stuck at this point of time to work on just anterior corneal surface without looking completely at the total surface of the cornea by doing a topo-guided treatment. The need is to improve the refractive outcome, possibly, not always. But what really makes a difference is it does make the patient better tolerate contact and glasses. So virtually it's a system in which you take the images from the topographer, which could be a topolizer, or a modified pentacam which is made for the wavelength, that is the oculizer, and then you transfer the image to the machine, and the machine corrects it according to an inbuilt mathematical nomogram. Is it required for all? I don't think so, because many of them are like Jatin mentioned, are very happy with the contact lens. Most of them are okay with the kind of quality of vision they have. But there are times when you can't fit contact lens properly. The pachymetry, 450 is the minimum. You know, what I look at it is at least 480 odd microns, because you are trying to burn some tissue. This is one of the parameters I took from Yatin's protocol, which is a little more aggressive. They say that at least at the end of it, with the epithelium, it should be 400 microns. But in our kind of progressive nature of cornea, 430, 440 microns should be in. That means it's very difficult to get a right case for this kind of treatment. But when you get one, this is what we do. We take the images from the machine, either a topolizer or oculizer. It can be transferred to the system, and then it's delivered to the laser machine. The whole aim of the treatment is to improve the central corneal symmetry, because you are looking at a very decentered cone, and so the symmetry is one which causes a problem. Trying to make it more aspheric. There are different ways of doing it. Unfortunately, the machine has got a proprietary software which they don't reveal too much how the machine actually corrects it. So that is something which is shrouded in mystery. That's the reason we need to do a lot of mathematical work just to get a proper neutralization. Many times when you talk about a topo-guided treatment, it's assumed that you load the data and the machine corrects everything. It just does not do that. You have to play around with a lot, because many factors play an important role. One of the most important role is like the cycle here, the topo-guided treatment. Are you correcting the refractive correction or not? If you're correcting the refractive correction, the cornea behaves differently. And when you correct the refractive correction, or you don't correct the refractive correction, the curvature of the cornea, that is the Q value, changes. So virtually, when you're playing with this, you correct the refractive, you correct the Q values, and that's where the mathematics plays an important role. Because the whole behavior of Q, or the shape of the cornea, the architecture of the cornea, is completely dependent on whether your cone is localized, centered, or decentered. And when you are doing the treatment, if you are not really looking at these aspects of it, then you end up in extremely complicated surprises, and that is something which is very difficult to handle. Sometimes it's worse than having a keratoconus itself. The whole idea is to make it more regular and aesthetic. It is not a refractive correction. This is what I tell all my patients. And it is not necessarily that it reduces your spherical equivalent. What it tries to do, it makes your quality of vision better, and that is what the whole idea of this is. I'll just run us a 30-second video on this. This is the front screen, and when you're looking at the topo guided, enter Q value. here, which says, because the machine would have picked up a Q value from a topologizer. Since in this patient the Q is very high, when it's more than 1, I try to keep it as close to 0, around 20% I keep it less. And then these are all the images which is borrowed from, come from the topologizer. We select a good one. And this is the refraction what the patient has. I mean, when you can enter the refraction, it's a 0.75 fourth diameter cylinder at 60 degrees. And then you need to enter the pachymetry out here and all the zones. If you don't do anything, this is what the machine would do. It would correct around 90 microns, which is not possible. So just to see how the machine actually regularizes the cornea, we keep everything at 0. That's the most important thing, because we are not trying to correct the refractive error out here. Keep everything 0, and then you off the till, because till, if you on, the machine corrects a lot of power. C4 is a defocus and C12 is a spherical aberration. What happens is, when you're changing the curvature of the cornea, the spherical aberration, if it changes, it will also changes your defocus. So you have to balance both. That means you balance the changing spherical aberration with the change of the defocus. So now you're trying to balance by adding a little power, plus or minus here. On this side it's a plus here. And when you try to balance these two values, now still it's not balanced. You keep adding, say I add a +1 out here, and then I get, which is close to, that's when you get balance. Once you get balance, you subtract the +1 from the 0.7 for what the patient has, and you get a +0.25. And you correct at least, I will correct around 30% cylinder, and then you say yes. So this is the confusion part, because and this is now you can see it's around 30 microns of burning, and then the rest is just the regular PRK procedure. So that so much of planning has to go into this to get a perfect system, because you are compensating for everything. You're compensating for an induced change, you're compensating for a spherical aberration change, you're compensating for a change in the curvature of the cornea. And that's where this procedure is little bit technically challenging when we start doing it, because just adding some values will probably not get what we want. And then immediately we do cross-linking. There being debate about whether you should do cross-linking later or you do one procedure at one time. What I follow and what many of us follow is you do simultaneous topo-guided and cross-linking. Again, the question comes, do you do an accelerated cross-linking or a regular one? What I try to do in most of this patient is I use a 9 milliwatt energy, because that is what is giving the least amount of haze. When you are actually treating the cornea, when you're burning tissue out there, I try not to use a mitomycin in that region. And if I use a 3 milliwatt energy, then I used to get a lot more haze than necessary, and being a cone being little central to create a more visual distortion. When I started using different parameters, I felt that 9 to 18 would give me a least amount of haze, and without using mitomycin, and that's what I use for all my topo-guided patients, because we want a little haze, because haze actually makes the cornea stronger. That's what Theo Sever says. And also we don't want too much of haze to cause the visual distortion. Let me know when I'm done, I can stop. And this is how it does. I have entered, this is my Q value, and ablation is 66. Is most of the time the ablation is in the periphery, and usually the central ablation will be less than 30. I try to keep it around 35 to 38 microns, because that's what I prefer, because this is the area of cone. And when you give a hyperopic treatment, what happens is this area becomes myopic and this area becomes flatter. So virtually the cornea becomes more aspheric, and that is what gives the quality of vision. Is like this, and you can see that whole change out here, but it just does not mean that it's made him completely normal. It's changed the whole refractive error, but what we actually look for is the scatter. An image which was not poor has become more regular, and this is a myopic thing, and then this person can probably get a better contact lens fit. They also sometimes we see a cone shifting centrally. When this happens, you can see that the decentered one has become more center, and this probably will get us a better contact lens fit. However, this will also induce in a huge myopic shift also, because this was around 57 diopters, now it's close to 60. So something which it used to make me worried initially. I'm treating something and the patient is going myopic. Many times the biomechanics of the cornea also plays a role, and once you center the cone, then probably fitting ICL would be a great idea in this patient, because you're reducing most of the unwanted aberration out there. The future is also going into this direction, not by using laser, but Evitro is coming out with a topo-guided cross-linking techniques where you're using the topo guide there and trying to link it with the machine, and it's trying to cross-link the area of the cone, and they expect that it will flatten by a diopter or two, which is without using laser. It also can be used to central the cone, central the decentered ablation. In this case, when we are planning a cataract surgery, we try to make it more regular and then probably do the cataract surgery. The question is this enough, or we try to do more? Because what we try to do is when the thickness is more than 450 is what we would do, and when it's less than 450 and we have an issue, we probably would protect the intact strings. I don't need to go into this. There are different options for it in the progressive keratoconus, decentered and advanced keratoconus. But the biggest challenge always been unpredictability, because there's no nomogram, there's a biomechanical aspect, the regression of rings. Poor biomechanics would, the patient would come back with a flattening initially, but they will always regress back. Cost, and it's always very difficult to fit in the contact lenses. That's what we have faced post the intact segments. Multiple papers have been done. Each one was following their own way of doing it. Started with Colin to different. These are two Kerarings, but all of them had the same issue of this. So we just published this recently, where we made a decision-free for intrastromal rings. Basically what we did was we used the traditional way of nomogram, which was being followed, and which we had around few patients there, and we used our nomogram and we compared between the two, and we found that when we use a nomogram which looks at the centered or decentered aspect of cone, we looked at all aspect of it, what is decentration, what is by definition on your topography, and how much of cone should be outside, and using the K values, and if follow the nomogram, we did find very good results, and I forwarded it to Sir also, because a lot of people during Cognac Keracon meet asked about this. So I don't know, we found it good, but when people start using it, they can let us know whether we need to do anything. For example, in this case, there's a superior-inferior asymmetry, and we look at the K values, and then go by this algorithm, and to an extent where if you have a spherical equivalent of 3 to 5, then probably a one ring or both rings. And in this case, you use this parameter, add it onto this, and then probably get this is the cone, and make one single ring in this case, and this is the results what we get, and this is a change what we see. Now we have for each of these topographies, and it tells you the axis and this the outcomes. There are cases when it's very decentered, then we also try to do a topo guided in this case, but these are the cases where the thickness is not great, so we just try to burn around 10 to 20 microns just to make it a little more regular, and then probably even you can use intact ring segments for these patients. We have at least 18 patients who are being followed for the last 3 years with this kind of a procedure, and recently there was an article published in JCRS also on this. So limitations of these procedures are the pachymetry, long-term stability. We have data now close to 3 years. We have around 3 to 4% of them do show progression, and most of the progressive ones are in the younger age group. And again, the refractive surprise what we see. Many things go into this. I'm not going to detail of this, but we know that there are genetic components of lysyl oxidase which play important role in the progression of keratoconus. And some of them do have a genetic defects which could create, even after you do a good topo guided or this cross-linking, still they can progress. The whole of epithelial profiling is very, very important, because you're taking the images from the epithelium and you're treating without epithelium. So that's also a big issue out there. The biomechanics is a major factor, because the worse the biomechanics, more unpredictable the results are. This is my last slide. Thank you.